From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. Today, we'll talk with one of the true giants of stroke neurology, Dr. Lewis Caplan. Dr. Caplan is professor of neurology at Harvard Medical School and a senior neurologist at Beth Israel Deaconess Medical Center. He's authored an enormous body of work, landmark papers, influential books, and clinical descriptions that have influenced how neurologists around the world recognize and classify stroke syndromes. But today, in addition to revisiting the past, we'll ask how he sees the future of stroke, bedside reasoning in an era of AI, and of medicine itself. Dr. Caplan was interviewed by Dr. Sarah Nelson, neurointensivist and assistant professor of neurology at Tufts Medical Center. Here's Sarah.
Dr. Caplan, thank you so much for joining us today.
It's a pleasure.
First, I'm wondering if you could take me back to your training. How did you become interested in pursuing neurology and stroke neurology in particular?
Well, I think the first thing when I was a medical student, there were two Dutch anatomists that came to the National Institute of Health that also spent some time at the medical school. They were masters of the metaphor and simile, and they made neuroanatomy really alive. People would come actually a half hour early to get a seat. And so I got interested in neuroanatomy. And then when I finished medical school, I was sort of on the fence whether I would do internal medicine or neurology. And as an intern and resident at the Boston City Hospital, the neurological cases were just the most interesting. They were the ones for me where I could really use my mind and that I was confident by taking a history and examining the people, I could figure it out. So I fell in love with neurology.
I wanted to ask you, what still surprises you or still makes you curious about stroke?
I think we're one of the things that's surprising is the number of patients that you think are going to be completely devastated, who seem to make a much better recovery than you think they would by the anatomy. That somehow everybody's brain's a little bit different, and some people who look terrible initially, you're surprised that they have an appointment at your clinic. They come 6 months later and they're in pretty good shape, and I think that's very surprising. I think also the diversity of the individual patients who you see and how effective or ineffective you are at convincing them to change their preventive strategies or change other kinds of things. The people are very heterogeneous and there's no right or wrong way to do it. I think also some of the newer techniques, especially looking at small vessel disease, have really changed. And I think one of the things that one has to get a hold of is that the milieu changes. So my mentor, Miller Fisher, he did some very elegant post-mortem studies in serial sections of blood vessels in people who had penetrating artery disease. But he was living at a time when they didn't have any really treatment for hypertension. And a
Hmm.
lot of the people had accelerated hypertension, very severe, often malignant hypertension. Now, we're in a little bit different era, and the pathology is quite a bit different, and we have different techniques and different ways of really studying the brain, both before death and post-mortem. So I think things are changing, and the presence of various kinds of risk factors is changing.
That makes sense. Are there particular technologies out there these days that you think has been a great advance for the field, or some that maybe shouldn't be using as much of, or maybe isn't particularly useful to us, you think?
Well, I think when a lot of the new techniques come out, we tend to oversimplify them a little bit. For example, the business about perfusion imaging. So, one of the principles that I think people found experimentally with this whole idea of the penumbra around the stroke, that is, that there were core areas in which there really was very little perfusion and the tissue was really dead or infarcted. And then there was a ring around that area in which there was suboptimal perfusion, but the tissue could be resuscitated and wasn't dead yet. And then we found out that there were all grades of that, that it wasn't necessarily all around in a very neat circumferential way. and that there was a lot of heterogeneity within that particular area, and that some of the areas that by perfusion techniques we thought were infarcted weren't actually infarcted. That if you did scans later and looked at it, the tissue seemed to somehow revive. And how that happened isn't clear. So I think the techniques, when they first come out, it takes a little bit of time and experience to really learn about them.
Thank you. Thank you. Back to yourself and all the wonderful contributions you've made to the literature, poster circulation disease, various types of stroke syndromes, intracranial hemorrhage, and certainly many others. Which contributions have meant the most to you?
I think two things. One is stroke registries and databases. We did the first actually stroke registry, which was a prospective registry, the Harvard Cooperative Stroke Registry. It was done with Jay Moore, who was at MGH at that time, and we very carefully, in a prospective way, collected a lot of data. The thing that really stimulated us to do that is we were asked to make a diagnostic program on a computer when personal computers first came out. And when we started to look, nobody really had a lot of data. How many patients were hypertensive? Were they severe hypertensive? Did they have diabetes? How often did the stroke begin when you were at rest? How much when it was active? Lots of these data items were just not available. And people were describing newer types of strokes. So we set out to actually accumulate the data. And ever since then, I've been tried to be very data-based in the sense we did after the Harvard registry, I was involved in the stroke data bank, which was more a national project. And then when I was in Chicago, we had a embolus computer collection program, a database. And then in Boston at your medical center, Dr. Delson, we did a posterior circulation database that accumulated the first 410 patients with posterior circulation disease. So then that really spread out nationally. So there were local ones, the French, the Germans, also started to get collection system, and we had some data that we could compare. How are patients in Boston different from patients that are in Germany, that are different from patients in other medical centers and of other mixed groups? The second thing is posterior circulation disease, which interested me from the beginning and which I've centered on, and I've written two fairly large monographs about the details of posterior circulation disease. First, what we were able to collect and the data from the posterior circulation registry. But then I realized you couldn't just present that. What you had to do was look at what people had said before the registry and how the registry actually changed data. So I spent 3 or 4 years really in the library looking up the literature that was available and tried to summarize that in the monographs. The third thing I think that a lot of people have quoted with me that has sort of been my mantra came from a small paper, "What's Wrong with Mr. Jones?" So I've always been for individual care and tried to emphasize that every patient is different. Their background is different. Their socioeconomic situation is different. Their age is different. Their comorbidities are different. Often their vascular lesions are a little bit different, and their deficits are a little bit different. So trying to homogenize it into groups that are from trials, and trials have to get enough patients, homogenize the data. They actually have large groups. Whether that information from the trials is really applicable to the patient who's sitting in front of you who you're caring for. It's really paying a lot more attention to that individual in every aspect. That's been one of my mantras and one of the things I'm proud of.
Thank you so much. Speaking of stroke care, neurologic care, a lot of things seem to be pretty protocol driven these days in our field. Do you think that this takes away from some sort of nuance or clinical pattern recognition? Do you worry that some of those things might be lost? And if so, what?
Yeah, I really worry a lot because I see happening now is especially young people are just looking at pictures and looking at images, that they're taking people in quickly and they're in such a hurry that they really don't get any reasonable history. So the history tells you really more what type of stroke it is and how it developed. If you get the timing and their background. So there is time while you're getting the patient prepared and they're getting the CT to take a very accelerated but a good history and then plan an exam, not just the NINDS scale, but an exam that would hit the main points of what the neurological deficits are, and then draw a hypothesis of what you think the cause of the stroke is and where you think it occurs. And with that as a background, the imaging is much more meaningful because you see a lot of things on the images that are unrelated and are not really telling you what's going on.
That makes a lot of sense. Out of curiosity, how do you think like a good balance is of trying to take a good but efficient history, but also making sure we're coming to appropriate localization and possible diagnosis in a reasonable time frame?
Well, I think it's gonna be training the residents much more. So much is done with algorithms and non-thinking and automatic that people have lost the ability really to think. People are becoming more people are becoming burnt out or losing autonomy. And I think in certain ways, the algorithm technique and the technology technique have left people not as much thinking and not as much satisfied with what they're doing. And I still think that taking care of neurological patients, particularly stroke patients, is the best job in the world. You know, you can do everything. You can think, you can really engage in patients very well. You have a way to really treat them effectively, and nobody else really can do that. The internists really can't. Most other subspecialists are not interested in it. So it's still a great thing to be a neurologist, but we have to keep in that individuality and the thinking process and not make it automatic, not have it be all, for example, AI. So you see a patient, you go to ChatGPT, you get a list, you put on the list, you do imaging on this, rather than really doping it out by yourself. Because the main thing for about neurology for a lot of people is the Sherlock Holmes approach, that you have a patient who is very needy, and with your mind and thinking logically, you can really do a lot of good for that person rather than just being an automaton that's using automated language or automated images.
I wanted to switch gears just slightly, Dr. Kaplan, and ask you a little bit about mentoring, which I know has been a big part of your career. What advice would you have for those new to mentoring or to new trainees seeking a mentor?
Oh, yeah. Well, if you think about yourself and what you produced and what you leave, it really is going to be surpassed. The technology and the other information is clearly going to be surpassed. And what you leave basically is the people you've mentored and the people you've taught. What you teach them or what you mentor them is basically a modus operandi. How do you approach a neurological problem? How do you approach a stroke problem? How do you talk to patients? How do you write? How do you behave with patients and with students and with mentees? And I think it's absolutely critical for residents and fellows and young neurologists to latch on to one or more mentors that they can use and call and can help them during their career with various kinds of things. I think that's the major thing we really do, that we really leave our legacy in the people that we've taught. And I've been fairly lucky because what happened basically, neurology is a fairly new topic in academia. It was really in departments of medicine. So really became a department only in the middle 1970s, early 1980s, and in Europe even later. So in the early 1980s, people who wanted to do neurology or stroke, they came either to the United States, and the major medical centers were basically Boston and New York, and to a certain extent, the West Coast. And that's where they got training. Then they went back to their countries and they set up a training program. Initially, the people who came over were supported and paid for by their countries where they were living. When they went back, they set up training programs so that the number of people coming to the United States in research programs or training programs became a lot less. So I was in the lucky period where we had a whole host of people that came as fellows. So when I was at Tufts in the late 1980s, we had as many as 6 or 7 fellows from all over the place, from Brazil, from Argentina, from Germany, from Great Britain, and then later, mostly from Asian countries, from Korea, from Thailand, from Japan. So I had the input of a lot of different people. It was like the United Nations. So in the posterior circulation registry, we'd meet in the evening and we'd go over case by case with a lot of input. And really that heterogeneity of input made it a wonderful kind of a session. So it was a matter of luck that I was there just at the time when all the people who were potential mentees were around, and I loved it.
Dr. Kaplan, it's really been a pleasure speaking with you today and to hear about your vast experience and the fact that you've cared for so many people over the years, many of whom have experienced catastrophic brain injuries. How has that shaped your own philosophy of medicine or even of life?
These things don't only happen in medicine, they happen in life. I mean, you have relatives that don't do well. We've spent, my wife and I, the last 30 years or so working with a group called Hospitality Homes, where we bring in our house people who've come to Boston for medical care and have, very serious diseases. And we see them, we interface with them. And it made us, more knowledgeable about the fact that, there but for the grace of God go we. And as you get older, you have more medical problems. So you become also a person who's using medical care as well as doing it. So it's made me much more emphasized about the people themselves and the importance of really getting to know the people and showing it, getting to know what their problems are, what their wishes are, what their long-term things are, and that it's very individual, that it can't be homogenized. And that's the secret of life.
Thank you so much again, Dr. Kaplan, for your time. I really enjoyed speaking with you and to learn a lot of information about you I didn't know was really exciting for me.
Thank you, Dr. Delson.
That was Dr. Lewis Caplan, professor of neurology at Harvard Medical School and a senior neurologist at Beth Israel Deaconess Medical Center, interviewed by Dr. Sarah Nelson, assistant professor of neurology at Tufts Medical Center. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Sarah Nelson and Sharon Aaron Govan. I'm Adeline Goss, podcast host and executive producer. Our production team this month included Sarah Nelson and Jen Hurley. You can listen to past episodes of the show, subscribe to us so you never miss an episode, and access all of the ANA's educational programs on the Education tab at myana.org. That's it for ANA Investigates. See you next month.